Hello and welcome to this destination policy update for the Shared Health Care Maps that's going to be published onto the Shared Health website on February 13th, 2024. So to start off with this, we're going to start with our standard destination. So this is where we're going to take our patients routinely. So this is going to be basically used on every primary call. So with this care map here, we're going to look at the indications. So like I said, it's all primary response calls. We're going to have to take our patients somewhere. So this care map here is to guide us to where we need to take these patients on our day-to-day responsibilities and our calls. So with that, there's really no contraindications. If we're not transporting our patients, we're not going to be accessing destination care maps. So with that, the first square here says, is there a designated hospital for the patient's condition for a specific condition? So with that, patients may also have a pre-approved destination for the patient. Some conditions require specific treatment. So it's asking, is there a preset place for this patient to go? So especially pediatric patients, some pediatric patients may have some congenital defects that can only be dealt with at Children's Hospital. So you may have directions stating that if this patient is sick, they go to Children's, bypass every other facility. That is where they need to go. If they do have a pre-approved destination, they must have the paperwork approving transport to that destination. So that's usually set up by Shared Health prior. If there is no documentation for that, we think it might just be parents saying, I just want my kid to go to Children's, even though we have to bypass a bunch of other hospitals. We can always contact Online Medical and see if they actually should be going to Children's or to the closest ED. And that goes with any kind of condition where they say, this is the hospital I was told by my doctor to go to. Again, they have to have paperwork. It can't just be, this is where I want to go. Okay, so we have to look into that first. If they do have the paperwork or they do have there is a designated hospital for this condition, we're going to go to that destination. So we look at table A here in the care maps. It has specific destinations, and these are for primary response. Okay, so with that, depending on what's going on with their patient, so again, trauma is going to go to HSC ideally. With palliative care, we have a palliative care admission care map. Cardiac arrest, again, we're going to reference our cardiac arrest care map. So again, this just kind of gives you a nice big breakdown. ACS goes St. B, acute stroke goes to Health Science Center or other stroke centers as per the stroke care map. So again, with that, we have things in place. So that's where we can take these patients as pretty much the standard. Is the patient's point of origin is closer to primary highway than any other regional hospital, we're going to transport as per care map B03, destination when the closest ED is in Winnipeg. So we're going to refer to that care map for transport. If there's a redirect advisory sent to us by dispatch through radio in saying which hospitals are open and the hospitals are on redirect, we're going to reference care map B02 redirection. If you're transporting CTAS 1 or 2, or your patient has a news score of 5 or greater, or there's any single 3-point parameter, we're going to transfer the closest ED regardless of border or boundaries. So you can go to any zone you need to with this patient. So in the care map here is embedded, we have our CTAS scores. So again, completed pre-hospital CTAS level 1 through 5. And then we also have our news 2 score here. So this is something new that's been added. It is a system for scoring the physiological measurements that are routinely recorded at the patient's bedside. So its purpose is to really identify acutely ill patients. So we're going to be looking for vital signs trending. So when we look at our scores, as you can see here, I'm not going to go through the whole thing. There's actually a course to take to understand news 2 more effectively. But with this here, you kind of look at your numbers. So we can see if the numbers are improving or getting worse. That's going to tell us whether our patient is improving or is degrading. So with that, if they do have a CTAS score of 1 or 2 with a news 5 or greater, we're going to transfer the closest ED regardless of border boundary. If the answer is no, we're going to transfer the closest ED within Manitoba. With that, we can also consider that patients with CTAS levels of 3 to 5 and a news 2 score of 4 or less, and there's no single 3-point score determinant, you can be transported to the closest ED within Manitoba. And that's our standard destination protocol. So we also have redirection advisories. So this is what I mentioned in the previous care map there. So with that, if there's any immediate emergency issues such as compromised airway, unable to oxygenate, ventilate, uncontrolled bleeding, imminent delivery, assistance required for delivery or resuscitation, we're going to transfer the close ED regardless of doctor availability and call Online Medical if no local MD is available. So again, the idea is that it's just better to be in a stable facility like a hospital. There might be extra hands there to help us. And we can put our medical directors on the phone as well with that hospital, and they can give directions to nurses if required to help us out as well. Is there a designated hospital risk conditions such as listed in table A and B01, so we just went over. So basically like stroke, acute stroke, ACS, things like that. If there's a pre-approved destination, like I talked about in the previous one, we're going to take them to those destinations. Are you transporting CTAS 1 or 2 or NEWS2 score greater than 5 or any single 3-point parameter? Transport the closest open D with physician available. So again, if our patient's really sick and unstable, we're not going to really go all the way to the city or anything like that. We're not going to bypass other hospitals. We're just going to go to the closest one that's available and open. Are there any other considerations? So with that, we can call online medical for clinical factors such as patient age, mobility, nature and severity of symptoms, the patient's ability to return home after discharge. Because again, if the closest hospital is 3 hours away, patients may not want to go to the hospital because that's really far and they have no way to get home afterwards. And the other thing as well, we have to look at the impact of long transport times as well. Is that going to be beneficial for everybody involved? So we can call in medical for that. We want to call on-call supervisors for issues such as transport conditions, such as weather or road conditions, excessive transport times, because even then we could look at legging. If our patient's stable enough, we could maybe have another truck meet us. Also, there's issues with staffing, paramedic fatigue. Like, is it realistic that we're going to be sitting in this hospital for the next 20 hours? So that stuff you're going to call OCS for. Or if you even just want relief in the hospital, that's an OCS call, not an online medical call. So with that, if there's still no other considerations, we're going to transport to the next closest open hospital. If possible, inform the patient's family prior to transport. So if we get there, like, okay, we're going to go to this hospital, then we get in the truck and they tell us, oh no, actually that hospital is now closed and we have to change our destination. Before we leave, we want to make sure the family and the patient are aware of that, because we need their compliance and their approval to go to that patient, to that hospital. The other thing as well is we have to ideally tell the family where we're going, especially if you're en route and you're like 30 minutes out and all of a sudden you need to redirect and the family's going to meet you at that hospital. Try to give them a call. That's why we try to get family members' phone numbers before we leave. So that way we can call the family and tell them that we're changing hospitals. And that's redirection advisory. So for this one here, destination when the closest ED is in Winnipeg. So this one's mostly been reformatted, but there are a few changes of note. So with this one here, underneath the care map here, so when we look at an imminent delivery, newborn resuscitation, cord prolapse, shoulder dystocia, or breech, we now have options of which hospital you go to based on where we are closer to. So now we can take these patients either to HSC Women's or St. Boniface Hospital. We have options. Another thing that's added at the bottom of the algorithm, it has closest ED of 17 years and older, children's ED up to 17 years. So it says in the care map, so that's 16 years and 364 days. Once they have their 17th birthday, they go to the adult side. The other big thing now that's really a big deal is patients can now go to urgent care centers. So with that, we can take patients to Seven Oaks, Concordia, and the Victoria Hospital if they are CTAS 4 or 5 and they are ambulatory. So if your patient has cut their arm and you bandaged up and they just need some sutures, we can go to urgent care. We don't have to be taking these patients to HSC anymore. The other thing as well in table C in destination Winnipeg, and this is a new big thing as well, for known or suspected hip femur fracture, excluding for major trauma, so they got hit by a car causing that, we're probably going to want to take them to HSC trauma center. But again, if it's just a simple trip, fall, hip injury in a geriatric patient, we can take our patients now to specific ortho hospitals. So with this here, this calendar is pretty standard. So Monday, Wednesday, Friday, we can take these patients to Concordia. Sunday, Tuesday, Thursday, we'd be preferred if we take them to the Grace Hospital. And Saturday, you can pick. So closest between Grace or Concordia. So that's the nice thing about urgent care centers. Now we can take them to, again, as long as they're stable. If they're highly unstable, we go to the closest facility first. And if transportation time is reasonable, like obviously, like it says here, if the closest ED is in Winnipeg, if you got a 1 hour transport to Winnipeg, we're not going to be going to these facilities. We're going to go to a closer facility. But if we're around the perimeter and we're closer, we can take them to these patients to these hospitals for ortho. So again, so that's destination when the close ED is in Winnipeg. I decided not to go through the whole care map. That's pretty much the only things that really changed with this. The rest of the care map is pretty much still the same. So with this one here, we have trauma destination for RHA and SHSS. So for southern geographical areas. Okay. So with this one, the care map has been renamed and there's been a change in contact for assistance. So for this one now for trauma, we're no longer going to call for online medical supports. As you can see, I've circled them all here. We are now to call for online trauma support. This has also been introduced into the new traumatic cardiac arrest care maps that are going to be published on the 13th. So when we call dispatch and request for support, we're no longer going to call for online medical. For trauma, we're going to call online trauma support. Okay, so we're going to switch up the language a bit there, so that way they have a better idea what we're calling them for. Is it medical or is it trauma? So again, as you can see, they're all circled here. All the different points have been switched from online medical to online trauma support. We have to make sure that we tell dispatch that when we phone in. And that's really the only change. So with that, it hasn't changed too drastically there. I just want to make sure that you're aware of when we make those phone calls, the terminology matters now. And that's just the few changes to the destination policy updates. So with that, thank you for attending and listening. And if there's any questions, feel free to contact me at emseducation@irha.ca. Thank you very much.